So, ma'am, we are starting, ma'am. Ma'am, we are starting now, ma'am.
Fine.
So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. So, the topic for today's webinar is urinary tract infections in pregnancy. I would like to welcome all the participants for their active participation, and I request them to post their queries in the comment box so that we can have a short QA session with the presenter at the end of the session. And now it's time to introduce our beloved Professor Dr. Shaanthy Gunasingh, ma'am. Madam is currently the consultant in OG. Madam was the past president OXY, former director and superintendent Institute of Obstetrics and Gynecology, Chennai. Madam was the former director and superintendent ISO KGH Triplicane Hospital, Chennai, and former HOD of OG department, Kilpauk Medical College, Chennai. Madam has served as a project director, Center of Excellence for Tubal Microsurgery in KMC for 6 years. And Madam was the past president, Women Doctors Association, Tamil Nadu, executive committee member, Chennai Menopause Society, and master trainer for basic emergency and comprehensive emergency neonatal care and tubal microsurgery, lactation management, and adolescent health. Madam has received Dr. A.L. Mudaliar Traveling Fellowship in 1993, and Madam is currently the invited speaker at various national and state level conferences. Madam is very familiar. Madam used to give talks in television shows for creating awareness among women. So, with this introduction, I welcome you, ma'am. And ma'am, before before going to session, I would like to take 1 minute of your time for explaining our Shield Connect web page, ma'am. So, yes, ma'am. So this is our Shield Connect webpage, ma'am. It's a new initiative of our Shield Healthcare, and it's a digital platform which contains a lot of information regarding women's health, ma'am. So it contains blogs. So I request you to share some blogs, which is going to be the need of the hour, ma'am. During COVID, we need more such blogs to create awareness among the doctors. And you can also see a separate page for webinars, ma'am. So all our webinars are conducted through our Shield Connect webpage. So you can find the details of upcoming and past webinars, which is available in our webpage, ma'am. And we also have a separate page for PCOS awareness. So you can find short videos of doctors explaining about PCOS in various regional languages. It is almost available in 6 or 7 regional languages around India. And we also have a separate page for our leaders, ma'am. So you can see a lot of doctors, that is KOLs, who are supporting our webpage through their webinars and sharing their scientific content in our webpage, ma'am. I request the participants to go through our webpage and make use of it. Thank you, ma'am, and over to you, ma'am.
Thank you very much for the kind introduction, Dr. Stalin. I thank Shield Healthcare for having given me an opportunity to share my views on UTI in pregnancy. Can I share my slides, please?
Yes, ma'am. Yes, ma'am.
Can you see my slides?
Yes, ma'am.
Okay. So the topic given to me is urinary tract infection in pregnancy. So urinary tract infections are the most common bacterial infections during pregnancy. They can be asymptomatic or symptomatic. Asymptomatic we see in the form of asymptomatic bacteriuria. Symptomatic we see in the form of acute cystitis and acute pyelonephritis. So we talked about asymptomatic and symptomatic UTIs, and then we should also know about recurrent UTI. So recurrent UTI may be defined as 3 or more UTIs in pregnancy. and they occur due to bacterial reinfection or bacterial persistence. And persistent involves the same bacteria not being eradicated in the urine 2 weeks after sensitivity adjusted treatment. So persistence means the same bacteria continues to persist. On the other hand, a reinfection is a recurrence with a different organism, or even if it is the same organism in more than 2 weeks, or a sterile intervening culture. So the incidence about asymptomatic bacteriuria is about 10 to 13%, but there are certain Indian studies which quote a high percentage of 24%. Acute cystitis is about 1 to 4%. Acute pyelonephritis is 0.5 to 2%. Whatever, I mean, why should we really bother about bacteriuria in pregnant women when they are asymptomatic? That is because although the incidence of bacteriuria in pregnant women is only slightly higher than non-pregnant women, the chances of progression to pyelonephritis is significantly higher, a whopping 40%. The rate of recurrence has not been calculated by any RCT or major study, but then we have a quoted incidence of about 4%. So why is UTI more common in pregnancy? The answer lies in the physiological changes occurring in the urinary tract during pregnancy. So we see a lot of changes in the urinary tract. Kidney size increases approximately by 1.5 centimeters. There is dilatation of renal calyces, giving a hydronephrosis-like picture. It may cause urinary stasis, thus increasing the risk of pyelonephritis. There is increase in glomerular filtration rate and renal blood flow rate. So these changes affect the pharmacokinetics of the drugs used in treatment. Ureters are also not spared. Growing uterus compresses and laterally displaces the ureters at pelvic rim. Ureteral compression and effects of progesterone cause a significant ureteral lengthening, dilatation, and kinking. These structural changes may give rise to hydroureter and sometimes obstructive nephropathy, increasing the risk of infection. Due to persistent pressure of gravid uterus on the bladder, there is marked thickening of bladder trigone, which can be seen even in ultrasound sometimes, and bladder pressure increases from 8 to 20 centimeters of water. Because of all these, there is significant vesicoureteral reflux during pregnancy, causing ascending urinary tract infection. In puerperium too, the bladder sensitivity to intravesical fluid tension is diminished because of labor trauma and epidural analgesia. And this aggravates things. And normal postpartum diuresis may worsen bladder overdistension, and catheterization to relieve retention often leads to urinary infection. So actually pregnancy and puerperium seems to be a conducive environment for urinary tract infection. So what are the risk factors for UTI in pregnancy? A pre-pregnancy history of UTI, lower socioeconomic status, sexual activity. Earlier, we used to talk about age and multiparity, but then now it is not talked about much. The recent studies do not talk about that. And some, on the other hand, talk about younger women being more prone for UTI. Anatomical urinary tract abnormalities are definite risk factors. Sickle cell disease and diabetes make it worse. Pregnant women have more sequelae from urosepsis. One possible underlying factor is a normal reversal of T helper cell 1 / T helper cell 2 ratio in pregnancy. So what are the predictors of UTI as the first prenatal visit? So we had a large retrospective analysis from embracing 8,037 women from North Carolina. It revealed that the two strongest predictors of bacteriuria at prenatal care initiation were UTI prior to prenatal care initiation, and a pre-pregnancy history of UTI. So how do we screen for UTI? Urine routine where we see pustules, microscopy, albumin being present because of infection, leukocyte esterase nitrite dipstick when the prevalence of asymptomatic bacteriuria in the population is 2% or less, dipstick culture technique, and of course, urine culture and sensitivity is the gold standard. And this is the leukocyte esterase nitrite dipstick, which would be a surrogate for urine culture sensitivity. So what about the organisms of UTI in pregnancy? The organisms that cause urinary infections are those from the normal perineal flora. So the common organisms causing UTI are Enterobacteriaceae constitute about 73.2%, E. coli 49.24%, Klebsiella 17.44%, Proteus 1.4%, Citrobacter 1.3%. But few studies quote E. coli as being the organism in about 70% of urinary tract infection in pregnant women. We also have the Enterococcus species, which contribute to 10.9% of UTI in pregnancy, non-fermenting gram-negative bacilli 8.2%, and Staph aureus 0.9%. So this is our own ICMR data, and 90% of E. coli strains that cause non-obstructive pyelonephritis have adhesins such as P and S fimbriae. These are cell surface protein structures that enhance bacterial adherence and thereby virulence. So this E. coli is a normal commensal in women. But then because of these P and S fimbriae and because of the pollinization of the uroepithelium, they become more virulent. So what is the clinical presentation of UTI in pregnancy? The most common form of UTI in pregnancy is asymptomatic bacteriuria. However, it may also present as acute cystitis or acute pyelonephritis after an untreated primary asymptomatic bacteriuria. So what exactly is the definition for asymptomatic bacteriuria? So persistent, actively multiplying bacteria within the urinary tract in asymptomatic women. And this significant bacteria is defined as bacterial monoculture in the quantity of more than 10 to the power of 5 colony-forming units per ml in 2 consecutive midstream clean cratched urine specimens, or more than 10 to the power of 2 colony-forming units per ml in urine collected from single catheterization of urinary bladder. So this is as per the definition of Infectious Diseases Society of America. But then RCOG clearly states that significant bacteriuria in one midstream clean catch urine specimen can suffice to be termed as asymptomatic bacteriuria. But then we should also note that it is prudent to treat when lower concentrations are identified in pregnancy, because pyelonephritis develops in some women with colony counts of 20,000 to 50,000 organisms per ml. This is only while relating to pregnancy. What is the significance of asymptomatic bacteriuria? If it is not treated, approximately 25% of infected women will develop symptomatic infection during pregnancy, and some papers quote 40%. Only 2.4% of treated women develop pyelonephritis, so it is really worth treating asymptomatic bacteriuria in pregnancy. So how do we screen it? AAP and ACOG, as well as US Preventive Services Task Force, recommend screening for bacteriuria at the first prenatal visit or at 12 weeks, whichever is earlier. Urine culture, of course, is the gold standard. but may not be cost effective when prevalence is very low, as less than 2%. So leukocyte esterase nitrite dipstick is cost effective when the prevalence is equal to or less than 2%. It has excellent positive and negative predictive values. This is the paper published in CMAG JAMC on recommendations on screening for asymptomatic bacteriuria in pregnancy. The conclusion was screening with urine culture during pregnancy and treatment of asymptomatic bacteriuria is a long-standing practice in Canada that may provide a modest reduction in pyelonephritis for women and may reduce the number of low birth weight infants. Serious harms from antibiotics, although possible, were not reported in our systematic reviews. This weak recommendation in favor of screening for asymptomatic bacteriuria in pregnancy recognize that some women who are not at increased risk of asymptomatic bacteriuria in pregnancy and are more concerned with potential harms of antibiotics may choose not to be screened or treated for asymptomatic bacteriuria. In such circumstances, there is potential value for discussion between clinicians and patients in order to reach evidence-informed and value-based decisions. This guideline, however, does not apply to women at increased risk of asymptomatic bacteriuria in pregnancy. So any high-risk woman has to be screened, no option at all. So we have finished about asymptomatic bacteriuria. Now coming to acute cystitis in pregnancy. 1% of all pregnant women suffer from that. They have dysuria, urgency, frequency, pyuria, and bacteriuria usually found. Microscopic hematuria is common. Occasionally, gross hematuria from hemorrhagic cystitis. Acute cystitis in pregnancy almost always results from ascending infection in long-standing asymptomatic bacteriuria. 40% of pregnant women with acute pyelonephritis have symptoms of lower tract infection. So if we aggressively treat such symptoms itself, then probably these women will not suffer from pyelonephritis. So lower urinary tract symptoms with pyuria accompanied by a sterile urine culture may be from urethritis caused by chlamydia trachomatis and sometimes from tuberculosis too. So coming to the third component, acute pyelonephritis. It is the infection of renal papillae and occasionally of renal cortex, so essentially of the kidneys. Most common serious medical complication of pregnancy, and it is the leading cause of septic shock during pregnancy. So pyelonephritis is unilateral and right-sided in more than half of cases and bilateral in a fourth of cases. So what are the signs and symptoms? Abrupt onset with fever with rigor, aching pain in one or both lumbar regions, anorexia, nausea, vomiting, and tenderness is elicited at costovertebral angles, more in second trimester, primigravida, and younger age. So what are the organisms involved? So E. coli in 70 to 80%, Klebsiella pneumoniae in 3 to 5%, Proteus 3 to 5%, gram-positive organisms including Group B streptococcus and Staph aureus in 10%. So how do we diagnose? So the diagnostic gold standard is renal biopsy, but this is highly impractical in clinical practice. So a combination of symptoms, full blood count, inflammatory markers, renal function tests, blood culture, urine culture, and sensitivity testing are used. So what are the medical complications that result from acute pyelonephritis? 20% develop acute kidney injury, and it may be severe enough even to cause acute respiratory distress syndrome. Endotoxin-induced alveolar injury are manifest in up to 10% of women and may result in frank pulmonary edema. And endotoxin also causes hemolysis and anemia in about 23%, and bacteriemia is demonstrated in 15 to 20%, and transient renal dysfunction can be seen in 2%. So what are the obstetric complications of acute pyelonephritis? Preterm labor, preeclampsia, chorioamnionitis, and postpartum endometritis. So what are the fetal complications? It affects both the mother and the fetus to a great extent. So low birth weight, prematurity, perinatal mortality, and developmental delay and mental retardation. So what are the differential diagnoses of acute pyelonephritis? So chorioamnionitis can be a result as well as a strong DD of acute pyelonephritis, appendicitis, placental abruption, and infarcted leiomyoma. So we have diagnosed urinary tract infection in pregnancy. How do we manage them? So asymptomatic bacteriuria, we have single dose treatment, amoxicillin 3 gram, ampicillin 2 gram, cephalosporin 2 gram, nitrofurantoin 200 milligram, trimethoprim sulfamethoxazole 320/1600 milligram. We also have the 3-day course, amoxicillin 500 milligram 3 times daily, ampicillin 250 milligram QID, cephalosporin 250 milligram QID, Cipro 250 milligram BD, levo or fluoxetine 250 milligram or 500 milligram daily, nitrofurantoin 50 to 100 milligram QID or 100 milligram BD, trimethoprim sulfamethoxazole 160/800 milligram 2 times daily. So others will be nitrofurantoin 100 milligrams QID for 10 days, nitrofurantoin 100 milligram BD for 5 to 7 days, nitrofurantoin 100 milligram at bedtime for 10 days, and treatment failures can be treated with nitrofurantoin 100 milligram QID for 21 days. But then we have to note that so many times there is bacterial persistence or recurrence. To suppress that, we can use nitrofurantoin 100 milligram at bedtime for the remainder of pregnancy. So how do we follow up asymptomatic bacteriuria? All pregnant women with asymptomatic bacteriuria should have periodic screening after therapy, since 1/3 of them experience a recurrent infections. Follow-up culture should be obtained 1 to 2 weeks after treatment and then repeated once a month. So how do we treat the persistent recurrent bacteriuria? As I already said, nitrofurantoin 50 to 100 milligram at bedtime until the end of pregnancy. But the most important thing is we have to do a urological evaluation postpartum in patients with recurrent infections, because they are more likely to have structural abnormalities of the renal system. So we talk so much about nitrofurantoin. So here we have the ACOG guidance on use of sulfonamides and nitrofurantoin for UTIs in first trimester. So this actually has been reaffirmed in 2019. So this recommends the cautious use of sulfonamides and nitrofurantoin in the first trimester of pregnancy due to possible risks of birth defects if no other alternatives are available. So the recommendations are prescribe antibiotics as indicated and for as brief a time as possible. Do not treat presumed contaminants found on urine culture, mixed gram-positive bacteria, lactobacilli, staphylococcus species other than Staphylococcus saprophyticus. If treating an infection in the first trimester, discuss with the patient risk benefits and fetal maternal adverse reactions. Sulfonamides and nitrofurantoin in the first trimester of pregnancy can be used if no other alternatives are available. If treating an infection in the second or third trimester, sulfonamides and nitrofurantoins may be used as first-line medications. Pregnant women should not be denied appropriate therapy because this causes serious risk due to both mother and fetus. ACOG also talks about penicillins cephalosporins, erythromycins, and surprisingly quinolones also, which is category C drug, were not associated with increased birth defects. So all penicillin, ampicillin, cephalosporin, erythromycin, augmentin, rifampicillin, gentamicin, oxacillin, even metronidazole, and quinolones. So we know about the US FDA, but now this has been replaced by another thing, but this seems to be very simple. Since we are treating two people, we have to use safe medication in pregnancy. The newer antibiotic is phosphomycin, which can be taken as a single dose. Broad spectrum antibiotics produced by Streptomyces species has bactericidal action. Single dose of 3 gram sachet. Category B drug, better compliance since it's a single dose. So last thing at bedtime after passing urine and at least 2 hours after food intake. So just prior to retiring to bed, this should be taken. This paper, which was published in Brazilian Journal of Infectious Disease, talks about bacterial sensitivity to phosphomycin in pregnant women with urinary tract infection. So out of 136 analyzed isolates, E. coli and Staph aureus were the main species responsible for UTIs among pregnant women in the study area. The sensitivity of isolated bacteria to phosphomycin was 89%, which indicates that it might be an effective, safe, and convenient therapeutic option for the treatment of uncomplicated UTI during pregnancy. So while treating acute cystitis, we have to increase the oral fluid intake, urinary antibiotics, urine alkalizing agent, cranberry, which also acts as a urine alkalizer and is used to treat urinary infection and ameliorate the symptoms. This is the article published in Clinical Nursing Research, which talks about the effect of cranberry on preventing urinary tract infection. So based on current evidence, cranberry can be used safely, but most important thing what we have to note is it has to be combined with antibiotics. This is a paper published in African Journal of Urology, which discusses about deep insights into urinary tract infections and effective natural remedies. So in summary, the existing data indicate the beneficial effects of cranberry preparations against UTI. However, these effects are mainly related to prophylactic activities by preventing the development of infection or in combination with conventional antibiotics, and solely intake of the herb is not recommended for UTI treatment. So this paper again talks about oral administration of D-mannose, where the bacterial numbers were reduced by 2-fold and 4-fold in the urine and bladder, respectively. What does NICE guideline, which was updated in 2018, say? So there were 2 RCTs by Wing et al., and they assessed the clinical effectiveness and safety of cranberry products for preventing asymptomatic bacteriuria in healthy pregnant women. They found that it was not very effective in preventing episodes of asymptomatic bacteriuria or UTI. However, a significant reduction in adherence was seen in women receiving cranberry juice compared with placebo. And they also assessed the safety and tolerability of cranberry capsules, found no significant difference in the number of babies born with a 1-minute Apgar score, less than 7 in women who received cranberry capsules compared with placebo. So it is quite safe in both mother and the baby. So how do we manage acute pyelonephritis? We have to hospitalize the patient, that is mandatory, obtain urine and blood cultures, evaluate hemogram, serum creatinine, electrolytes, especially CRP has to be taken, and monitor vital signs frequently, including urinary output, and we have to consider indwelling catheter. We have to establish urinary output at least 50 ml per hour with intravenous crystalloid solution. And it is important to administer intravenous antimicrobial therapy. If there is dyspnea and tachypnea, then chest radiograph can be taken, shielding the abdomen. We have to repeat the hematology and biochemical studies in 48 hours and change to oral antimicrobials when afebrile and discharge when afebrile for 24 hours. We have to consider antimicrobial therapy for 7 to 10 days. Some even quote the total duration to be 10 to 14 days. We have to repeat urine culture 1 to 2 weeks after completion of antimicrobial therapy. Non-steroidal anti-inflammatory drugs have to be avoided in pregnancy because they will have an adverse effect on the fetus. Thromboprophylaxis should be used if the woman has reduced mobility or a period of bed rest. The use of graduated compression stockings and low molecular weight heparin is advocated. Tocolysis is frequently necessary because of the irritability of the uterus. Antenatal steroids for fetal lung maturity should be considered if there is evidence of threatened preterm labor. So what are the antimicrobials of choice? In mild or moderate acute pyelonephritis, ceftriaxone 1 gram every 24 hours. This is what is given, but generally in ours, it is given twice a day. Cefepime 1 gram every 24 hours. Amoxiclav 1.2 gram every 12 hours. But this might not be good in term pregnancy for fear of necrotizing enterocolitis for the fetus. Astronam 1 gram every 8 to 12 hours. And in severe acute pyelonephritis and immunosuppression and urinary stasis, ticasulin with clavulanic acid 3.1 gram every 6 hours. Piperacillin with tazobactam 3.375 gram every 6 hours. Meropenem 0.5 gram every 8 hours. Ertapenem 1 gram every 24 hours. Doripenem 1 gram every 8 hours. So the piperacillin, tazobactam and meropenem are commonly used in our part of the country in severe acute pyelonephritis. What if acute pyelonephritis does not respond to treatment? Generally, intravenous hydration and antimicrobial therapy are followed by stepwise defervescence of approximately 1 degree Fahrenheit per day. So the fever comes down, patient feels much better. But then with persistent spiking fever or lack of clinical improvement by 48 to 72 hours, it is persistent infection. So what are the causes of persistent acute pyelonephritis? Urinary tract obstruction, abnormal urethral and pelvic calyceal dilatation, intrarenal or perinephric abscess, and nephrolithiasis. Especially women who have Staghorn calculus develop a very florid form of acute pyelonephritis. So how do we manage persistent infection? Ultrasound KUB should be taken. 1 shot intravenous pyelogram. IVU is not contraindicated in 2nd or 3rd trimester. MRI also can be used to detect the cause of persistent infection. The most important thing is relief of obstruction. So this can be done by cystoscopic placement of a double J urethral stent, percutaneous nephrostomy, or surgical removal of stones. So what is the cause of recurrence even in low count bacteriuria or even negative cultures? So many times we see only 10,000, 20,000, or even cultures are repeatedly negative. The answer lies in intracellular bacterial colonies forming biofilms. So what are biofilms? Uropathogenic E. coli like E. coli CFT073, UTI 189 and 536 invade urothelial cells lining the urinary bladder, which forms intracellular bacterial communities or biofilms. So they are essentially intracellular. So the infection remains undetected in normal urine cultures, causes recurrence. These culture negative infections present as unexplained dysuria and urgency and are termed as interstitial cystitis, bladder pain syndrome. So these biofilms can also result in resistance, antibiotic resistance. So this is the paper published in Asian Pacific Journal of Tropical Medicine. So in vitro biofilm formation by uropathogenic E. coli and their antimicrobial susceptibility pattern. So here it was noted that antibiotic resistance was 100% for chlorphenicol and amoxicillin, 86% for gentamicin and cefotaxime, 84% for ceftazidime, 83% for cotrimoxazole and piperacillin tazobactam, 75% for tetracycline, and 70% for amikacin. So how do we prevent recurrent infection? But as I said earlier and reiterated many a time, continued antibiotic prophylaxis till the end of pregnancy in the form of nitrofurantoin 50 to 100 milligram Hs, intake of 150 to 750 milligram ml of cranberry juice or concentrated equivalent is effective in preventing recurrent UTIs. When juice is generally not preferred because the amount is too much, it also needs a lot of sugar to be added to be palatable. In that event, it might not be good for GDM. That we should always remember, and we should also think about the calorie content when lot of sugar is added. So probably tablets would be better, and maintaining the local hygiene, drinking at least 3 to 4 liters of water, and women who are sexually active can be advised to practice postcoital voiding. That really helps a great deal. So to conclude, bacteriuria in pregnancy is common and is a serious cause of maternal and perinatal morbidity and mortality. Clinical presentations include asymptomatic bacteriuria, acute cystitis, and pyelonephritis. Screening urine culture at first visit is recommended by both ACOG and RCOG for detection of asymptomatic bacteriuria. Bacteriuria may more commonly progresses to acute pyelonephritis during pregnancy. All pregnant women with bacteriuria should be treated and followed up. When choosing an antimicrobial, the pharmacokinetics and bioavailability of the individual drug in pregnancy must be considered along with the resistance profile of the microorganism. Simple behavioral changes and continuous antibiotic prophylaxis can prevent recurrence of UTI in pregnancy. Thank you very much for the patient hearing. And I once again thank Sheel for having given me an opportunity. Thank you very much.
Thank you, ma'am. Thank you very much for that detailed presentation, ma'am. Untreated UTI is associated with risk in both the fetus and mother, ma'am. The sooner you treat it, the less likely the UTI will become serious, ma'am. Thank you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. I will read out the queries if there is any in the chat box. There is one question like, if the patient is diabetic with chronic recurrent UTI with chronic super added fungal infections in first trimester of pregnancy, ma'am. Ma'am, you have to unmute, ma'am. You are on mute, ma'am.
See, fungal infection in the groin. Is that the question? See, diabetes that is there. And then what else? Can you just read?
Patient is diabetic with chronic recurrent UTI with chronic super added fungal infections in trimester of
fungal infection in groin. That is what they mean, or do they mean in urine?
That they are not.
Yeah, yes. But I think what they mean is just fungal infection in the groin and external genitalia, probably. So one thing is good control of diabetes. So probably here, this is one place where insulin will really help. And then, of course, we aggressively treat the urinary infection and fungal infection will get controlled once diabetes is controlled, and topical antibiotics will really help. If it is in the urine, then it becomes she needs an ICU admission problem. She needs an intensivist to be managed by intensivist.
Okay, ma'am.
Chlamydia in human, what is that? We can, certain things like candida can be easily treated if sugar is controlled. That we see so many times in the urine. If it control the diabetes and then give topical, antibiotics, topical antifungals rather in pregnancy, that itself treats the candida.
Okay, ma'am. Ma'am, another question is there any chances of antibiotic resistance development during this pregnancy, ma'am?
There can be. That is what we talked about, biofilms and all that. So urine culture sensitivity is the gold standard. So anyway, once we might start on empirical antibiotic, but initially we have to give a urine culture, start on empirical antibiotic, then within 48 hours, the results will be available. You switch over to the antibiotic where sensitivity is seen, give it appropriate for the appropriate time, and then after 1 to 2 weeks, we have to repeat the urine culture. So if we do like that, there might be recurrence, there might be persistence, but then there will be some antibiotic to which the organisms are susceptible.
Okay, ma'am. Ma'am, another one question is like, what is the safety profile of this quinolones and phosphomycin in first trimester of pregnancy, ma'am?
That is what I said. See, quinolones generally we do not use. It is category C drug. It has an effect on the cartilage, especially on the fetus. So generally we do not advocate, because we have better drugs. All these cephalosporins, all these can be extensively used. I was really surprised when I saw the ACOG recommendation. That was based on a extensive population-based study. But I really feel first trimester we have to be careful. Cephalosporins are category B drugs. That would be ideal. Phosphomycin is also a category B drug, but we do not have, it has not been extensively studied. So we have only few papers on that. So if we have sensitivity to other drugs, I think it would be wise to use them in first trimester.
Okay, ma'am. Ma'am, how to manage fever due to UTI in first trimester of pregnancy, ma'am?
The most important thing is it can be a cystitis, or if it can be a pyelonephritis. So cystitis is lower urinary tract infection. So we have dysuria, frequency and all that. Fever can be there. But then if it is high, with chills, with loin pain, then it is acute pyelonephritis. So the most important thing is we have to differentiate between these two, because acute pyelonephritis is an medical emergency. Patient needs treatment, hydration, adequate hydration, good evaluation, intravenous antibiotics. So usually if it is cystitis, we just give oral antibiotics, then for 7 days, then 1 week later, 1 to 2 weeks later, it can be repeated. But then if it doesn't get controlled, fever with rigor can be there, but if it gets controlled, that is fine. If not, patient has to be admitted, and intravenous antibiotics and treatment by opinion by intensivist would be really welcome.
Okay, ma'am. Ma'am, another question is like, is there any difference in terms of severity of UTI?
Pardon?
Yeah, ma'am. Ma'am, is there any difference in terms of severity of UTI in the early and late trimester?
See, the thing is, cystitis and all that doesn't have much difference. But then pyelonephritis, because of the physiological changes, especially when certain women have gross hydronephrosis and stasis is marked, or when they have concomitant renal stones which are causing obstruction, then probably second and third trimester it is more. But otherwise, it doesn't have much effect. It is the same everywhere.
Okay, ma'am. So, ma'am, I don't find any other questions in the chat box, ma'am. So, if you allow us, then we can end the webinar for today, ma'am.
Okay, thank you very much.
Thank you very much for being with us today and spending your valuable time with us, ma'am. We are looking forward for many more webinars with you, ma'am. Since it's being a pandemic situation, we need the guidance of such a senior doctor like you to engage the junior upcoming doctors, ma'am. So thank you, ma'am, and I would like to thank all the participants for their active participation, and I would like to thank my colleagues who made this webinar possible, ma'am. Thank you, one and all, ma'am.
Thank you.
Thank you, ma'am.